We'd like to welcome you to the CERSI lecture today, hosted by the Yale-Mayo Clinic CERSI, and the presentation will be from Dr. Morris on the rise of point-of-care manufacturing, the Mayo Clinic experience. Dr. Morris is a neuroradiologist in the Department of Radiology at Mayo Clinic. He received his MD at Howard University College of Medicine, completed an internship at Washington Hospital Center, 3 research fellowships at National Institutes of Health, and his radiology residency and neuroradiology fellowships at Mayo Clinic. He's a board-certified radiologist, CAQ neuroradiologist, and director of the 3D printing anatomic modeling lab at Mayo Clinic. His special interests are the use of 3D printing for preoperative planning and custom surgical guides. He's the medical director of advanced biomedical visualization at Mayo Clinic. Clinically, he focuses on minimally invasive thermal ablation of tumors in the neural axis. With that, I'd like to turn it over to Dr. Morris. Thank you, Dr. Morris, for presenting today.
Yeah, thanks, Dr. Shaw, for letting me give this lecture. So I'm going to talk a little bit about point-of-care manufacturing and what our experience has been over the last 15 years or so. And we'll start with a little bit about Mayo Clinic, talk about an integrated team, what medical 3D printing brings to that, and some future. And one of the things I think that is important is that at Mayo Clinic we have integrated multidisciplinary teams of people. So surgeons working with medical doctors, working with radiologists, all on multiple teams to provide the best possible care for patients in each subspecialty. And it's no surprise then when we incorporated 3D printing as a tool for our surgeons and our clinicians that continued. And now that 3D printing has just become one more part of that multidisciplinary team. A big part of that is having engineers in the clinical service, and while we have 70 engineers at Mayo Clinic for custom medical device creation and other things as part of our ecosystem, that's without an undergraduate institution. Really, we hired biomedical engineers like our senior engineer seen here, Amy Alexander, into a department. So she works for the Department of Radiology as does our other engineer, Hunter Dickens, and she is part of the clinical team. And that has really driven collaboration. And this is a chart here that shows communication on the y-axis with physical distance on the x-axis. And you can see that this was initially done in the 70s, repeated later with social media and email. And it always holds true that the closer you are in physical distance, the more communication that occurs. Now, we're all social distance now, and we're finding ways to communicate, but the organic type of communication I'm talking about, as we'll see, is because we're working near each other. And this is one of the rooms we used to have for 3D printing. We just finished 8,000 square feet of manufacturing space in the hospital. So we're not down the street. We're not in an undergraduate engineering lab. We're in the hospital above the ORs. But, you know, we have radiologists that are subspecialists. We have subspecialty surgeons. We have biomedical engineers, healthcare technicians, and other people that freely float in and out of our space, where a typical day, these were shown with my iPhone, could look like this. There's a team coming on rounding, doing virtual surgical planning. There's another team coming to pick up custom medical devices, which are been 3D printed and are going to be sterilized in the autoclave. And it's a free flow of people and ideas throughout the day. Medical 3D printing, without going into too much detail, one of the things you should take away is that it's an umbrella term. So there's multiple different technologies, and each technology does something specific to its own technology. So when people ask, what type of printer should I buy? How much does that cost? How long does it take? That all answer, the start of that answer always is, it depends. Because no printer does it all. And sometimes you might want clear. If you're trying to show something behind something. Sometimes you might want color, and you might want binary colors to show where tumors are. You might need flexible material, like if you need to do simulation on a patient's chest or land a valve inside the heart, or do patient-specific simulation for bronchoscopes or aortas. You might need sterilizable materials where you're going to screw a 3D printed object on a patient. And I will warn you ahead of time, if I remember to, that there will be graphic photos throughout this because I wanted to show you how we're really using it rather than just cartoonish versions. because many times we have to sterilize 3D printed parts which are going to the operative room for reconstruction. And we're just getting into titanium, so we put in a titanium printer at Mayo Clinic last year, and it's being converted into a GMP and an FDA-approved manufacturing facility. But we do print in metal. Right now we're liaisoning with medical device companies. Most of what we do starts with imaging. It gets imported into a software. We use a Materialize for a CAD software. We segment, meaning we pull out the parts of anatomy that we want, and everything we want in 3D printing, if it's a different color, it's a unique CAD object. We create a mesh, and then we send it to one of 18 different printers, and then it goes through one of the steps of post-processing. We started really with conjoined twins, but I show this collage because we're baked into the fabric of almost every surgical department now to where 3D printing cannot be separated from clinical care. We did start with these girls who were connected at the chest in 2006, and their livers had to be separated, their chest cavity had to be separated, and it's a complex organization where 50 people were going to come together. And really what the surgeons asked us initially was, can we make a little version of their liver? And this type of communication here between surgeons working on a life-size physical object is exactly what happens today, because you want to know everything you're going to need to do before you get to these critical moments in a complex case, but also some of the more basic cases. And as these girls have grown, our lab has certainly grown. We quickly moved into spines, and not the standard S-shaped scoliosis spines, but really complex spinal deformities that needed to be reconstructed in ways where surgical navigation just wasn't enough to perform it safely. Sometimes people ask those questions like, well, if you're a radiologist and you make all these fantastic images that are in 3 dimensions, that are full color, why is that not good enough? And I think to answer that, one of the reasons is it's not life-size. And there's another whole reason which gets glossed over a little bit when we talk about 3D printing, and that's the ability to have haptic perception, meaning that you can understand whatever you're looking at because you're handling it at the same time that you're looking at it. And this on the screen versus this in the surgeon's hands are two different things. And sometimes there's so many things wrong that we don't pick up things, like they have to intubate the child or they have a critical tracheal stenosis. Well, when 50 things are wrong, you might miss some critical things that are easy to see on the model. I show this confidence graph because I think it really helps understand how we go from a place of no information to a place of complete information, and I really think that's where you want your surgeon to be. So when a patient comes into your office, you might order x-rays, you might order CT scans, you might order MRI scans, but really the surgeon has to do all the mental gymnastics to sum it up to just create an object that he's going to have to put back together with multiple screws and rods, which have to be within 2 to 3 millimeters of tolerance in a really complex patient who is active. Even though we told him he shouldn't be hunting after this surgery, he still made a shed. We live in Minnesota. People love to hunt, and mounted his hunting rifle on the shed. So we want to get people back to the quality of life they had before we met them. And 3D printing helps. For spines, we went right into tumors because the spine surgeon who does tumors said we have complex cases. I might have to remove the carotid artery out of the way, which feeds your brain. I might have to take a large piece of the bone out. I might have to remove the clavicle. And I don't get a second shot at this. I don't get a chance to practice. I don't get a chance to figure out how I want them on the table. And these models have been incredibly helpful for that. But also, if you're going to do that to, say, a 12-year-old child, the surgeon has to go out and communicate all this, risk of stroke, risk of paralysis, to a family member who has no understanding of the images you're about to show them. So for patient consent all the way through surgical training, this has made a dramatic impact in patient care. And once we started doing tumors, there really was no going back. So I'll talk about some clinical use case scenarios, and we'll move rather fast so I can show you a large breadth of cases. In craniomaxillofacial, the way that you interact with the world is through your face. The way everybody views you for your initial meeting is through your face, your emotions, and we're trained to see people symmetrically. So if your lip is down, if your eye is droopy, if your eye is back or forward, people notice immediately that something is wrong with the face. And so while we want to make patients like this tumor-free, we have to deliver them back to the world where they can interact with society in a meaningful way and not feel so maimed that they're unwilling to go out in public and lead a normal life. Here's a young woman who had a tumor on the roof of her mouth. You can see it there on the right. It's the little pink thing going up into the skull there, which is one of the reasons we have radiologists here, because only a radiologist will know where the borders of that tumor is. And sometimes they'll ask us to 3D print objects because they say we're going to have to take this piece of her mouth out and put that part of her shoulder blade in, and it's a sizing issue. How do you know exactly what size this is going to be? And what they do on the models is they pre-bend all the plates that are going to have to fit into the body instead of pre-bending plates on the patient who's open under anesthesia, which leads to not only being cancer-free, but also morphologically looking normal and allowing someone to be able to put teeth inside of there. If we need to take out mandibles, the choice of bone is the outer leg bone called the fibula. It's a fibula-free flap. One of the reasons we use it is it stands up to radiation. So while virtual surgical planning was not invented at Mayo Clinic, it was first published in 1994, we have brought every step of that process in-house instead of working with medical device manufacturers over Skype. And here you can see a patient that we create in the image acquisition protocols for. We segment out a very large tumor. The surgeon walks up during his normal daily hours in the hospital when he's available, not when we're available. He simply tells us where he wants to cut. He then leaves this area, and we design with our biomedical engineers who are in the conversation with the surgeon how we're going to make these cuts. The dentist decides where we're going to put the teeth and the teeth post, and we can create a custom solution with a custom titanium printed plate that fits perfectly for just this patient. And then we do sterilizable Class II medical devices printed on site. We've done a lot of work to create the quality management system, the biocompatibility, the sterilizability, which is beyond the scope of this talk, to be able to make sterilizable devices using 3D printed for patient-specific applications at the point of care. And that those cutting planes from the mouth have to be transitioned down to the leg, so when we cut the leg bone, it all fits together. And that little piece of plastic there, when it's all said and done, is $20 of raw material. Now, it costs a few $100s when you consider the entire ecosystem. However, if you buy that on the open market, it can cost upwards of $3,000. So we're reducing costs, we're doing it faster, we're doing it more customized and better based on surgical desires, and we're able to move that to other parts of the body. These fixation trays are something we invented because the surgeons say, even when I take the bone out, I need a place to put it all back together. So we created this fixation trays just by having the engineers in the OR and recognizing, oh, I can solve that problem. Come upstairs, designed in a day. Next case, it's implemented. And here you see the teeth posts. And then we do about 200 to 300 cases like this a year just for craniomaxillofacial, not for orthopedics. So it is the standard of care at Mayo Clinic to 3D print sterilizable patient-specific osteotomy guides for tumor resections that are going to be screwed on an open face. So they have to work, they have to be accurate, they have to be biocompatible and sterilizable. Now, when we're taking the midface apart, it's a little harder than taking the mandible out because the eye is involved. We might have to remove the eye. And again, we do virtual surgical planning, making multiple cut planes, moving the fibular scapula. Here we mirror image the normal side to the abnormal side, which we do a lot in trauma in order to make a perfected anatomy. And then we make the titanium plates to fit only that patient with the perfected anatomy, so that at the time of surgery, that little device goes on the leg and the fibula. You can look away if you want. So when we deliver this to the OR, once they make their incisions, that is screwed on the bone, and we're putting a saw through there that only fits this person. It is patient-specific, customizable care that only is for this patient. So we have a defect that leads to a custom implant that only fits in this space. And that saves 2 to 3 hours in the OR at $80 to $100 a minute for that patient. So we get better outcomes with less cost, faster with a faster turnaround time. And these are the type of quotes we get back, not just from craniomaxillofacial, but from every bit of care that 3D printing has allowed really good surgeons to take a patient like this, remove half of their jaw, and deliver them back to the world looking normal, feeling normal, but also cancer-free. In thoracic surgery, we have multiple talented surgeries that have to remove large pieces of tissue, and traditionally they'll do it through large incisions, like these incisions drawn in black on your right, which means you have to saw through multiple ribs, which can be painful. But our surgeons wanted to do more and more things minimally invasive, which means you have a smaller view of what you're going to take out. So when you look at a tumor, like this tumor, it's called a Pancoast tumor in the right upper lobe, you can see that the surgeon is going to be looking at it from below. But everything that's important to this patient besides the lung, such as the bronchus, such as the blood vessels that feed the arm, such as that drain the arm, the nerves that can cause damage to the hand are all on the other side where she was not able to see. And if you want to do it minimally invasive, you have to not understand just regular anatomy. You have to understand the patient-specific anatomy that's been moved by a tumor. So when you're looking up into the chest, you don't see that. But by giving them anatomic models allows them to remove these tumors through a smaller incision, less morbidity, less time in the hospital, less time under anesthesia, which is all a big win for that patient. And in doing so, we end up printing a lot more tumors in the chest because it was so helpful. Our surgeons won't come back to us if it wasn't helpful. They'll say, that's nice, it's new technology, interesting, but we don't need it. And when they come back time and time again, you know that you've made something innovative that's really helping patients care. And in this case, the patient is able to look at his own chest, look at his own tumor, and understand the risks. Sometimes we have to take out big pieces of the chest, and we're going to have to put something back in there, so sizing becomes a big issue. Sometimes we're taking out really vascular, bloody tumors right from the middle of your chest, and this red vessel is the largest blood vessel in your body that's pumping out blood from the heart 5 liters per minute. And if you damage it or get into a bleeding tumor, it's a difficult place to operate. So they ask us to make these models. The little purple things or fuchsia are all vessels that they have to take care of. And the surgeons come right up after the surgery and say, I was able to get this out with minimal blood loss, which can range in these tumors up to 6 liters, with minimal blood loss at a very fast time because I had a roadmap that told me where all the critical structures are. Similarly, if we want to do minimally invasive approaches to the chest, we're going to have to know exactly where an artery and vein is and exactly where a bronchus is, because the view you get is not of the forest. It's of a very small area, and they ask us to 3D print these so they know, okay, I'm looking at this, right next to that should be this, and here's the tumor. This case was from 2 weeks ago. There's a little green tumor in the trachea, and you're looking at it from the back. When you're on the table in the OR, they're going to be coming at it from the front. And the typical approach is to split the sternum down the middle and resect it. Now, this is the surgeon's view, so he has to have a vascular surgeon help mobilize these vessels that feed and drain the brain. We gave the surgeon this model, and again, this is somebody who's been working here 15 years doing thoracic surgery, and he said, well, I realize I can't come from the front. And you'd say, why not? And he said, well, this is in the way. I can't work from this angle. I can't look at it from this place, and I have to sew the trachea back together. I'm going to come from the side because it's a straight shot at that. Now, we had MRI, we had CT, we had PET scanning, but this little model, which is probably no bigger than a Big Mac, for lack of a better word, changed the position. The patient was going to be in the OR and change the surgical approach, which happens about 20% of the time at Mayo. And here's the tumor from the inside, and I can tell you from the outside, you can't see the tumor. So this blue rope here is around the trachea. You can't see the tumor. So he's using spatial relationships to say, I can only take so much of this structure. I need to be right and not cut through the tumor, so that when I'm looking at it, and I've cut a piece together and sewn it back together, I only take out the little piece of tumor I have. And that little model changed everything about the way that tumor was taken, because even with imaging, even with a scope looking at the tumor, even with PET, advanced things, it's difficult to do the mental gymnastics it takes to make all that three-dimensional object in your mind. In neurosurgery, we focus mostly on skull-based tumors. This is Mike Link, one of our skull-based surgeons, of which we have 2, and I'm our third. Jamie Van Gumpel is our second. And the surgeons want to know in a patient that's been operated on, where are the critical structures? Where are the nerves? Where are the arteries? Where have they been displaced? When I take this tumor out and remove all that purple, how much space is going to be left, and how am I going to reconstruct the skull base in a patient that's already been operated on the outside? So this is a complex case made more complicated by somebody previously operating on it and previously radiating it. It's incredibly challenging, so they asked us to make these models to understand those critical anatomic relationships. Now, in this case, you can see the large purple tumor coming out of the skull base. The artery in the front feeds the brain. It's going to have to be mobilized. And how do you discuss with a patient that this is where this tumor is, and there's a chance that you might never eat again, swallow again. We might have to have a breathing tube in for life because these nerves come out of a hole that go into this tumor. So here's the informed consent process. You'll notice there's no computer on. There's no pictures on the screen. There's no complex discussion. This is your skull, your tumor, your blood vessels, your independent risk factors. And the discussion goes a lot better for somebody who's facing incredibly challenging resection. And then it can be referred to in the operative room at the time of care, as well as for training our residents and fellows. It allows surgeons to look at, say, an infant's head, a one-year-old, a 6-month-old head, look at a vascular anomaly that you get one shot at curing. When you're in there, you can't do this. You can't look at the forest through the trees. You have to come up with a plan and perform the operation without rehearsal. And these models, which are rare pediatric vascular anomalies, allow them to think about things before they're there. When patients have hemorrhage, this white stuff is hemorrhage in the brain. It's from this little aneurysm at what's called the basilar tip. That is an incredibly dangerous place to get to fix this little tiny aneurysm, which may be able to hold a coil, but you might have to do an operation where you're coming past the eye all the way back to the back of the head. And to be able to simulate those things using 3D printing to understand the relationships has been crucial. In vascular surgery, it's no secret that we used to open people up to do aortic repairs, and most of that has gone to endovascular repair for most aortic and iliac aneurysms. However, we had surgeons who wanted to be able to reconstruct the entire aorta using percutaneous means, and that process just wasn't available in the past. So you have new products on the market, steep learning curves, using devices to do things that have never been done before. 3D printing is great for that, and I'll show you this index case, which was a patient who came to Mayo Clinic who had a thoracic aortic aneurysm that was crossing the blood vessels that go to the brain, and this didn't exist on the market at the time, this stent, where you put a stent inside of one stent and you go to the next stent, you disconnect this vessel from this arch, you connect this all the way across, you have a carotid-to-carotid subclavian bypass. It's an incredibly challenging thing to do, and it has not been done. So our surgeon, who's working down here on the first floor, came up to us on the 6th floor, and we drew out a patient-specific simulator, what we wanted to connect to, what we wanted to do with it. Again, because we're in the hospital, he knows us, he works with us clinically, and we created this patient-specific simulator. Cook created a patient-specific device, and within 4 days, from Thursday to over the weekend to the following day, they practiced putting these stents in this patient in a controlled environment, a relaxed environment, realizing all the steps it was going to take. Here's the surgeon, Dr. Oderich, and then deploying in an OR with a large amount of people, including the possibility of having to open him up, of which he wasn't a great surgical candidate for. So all that happened in 4 days, and the average stay for an open surgery is 10 days. So if you can do that all interventionally through the groin, then you, one, avoid an extremely large incision from the armpit down to the iliac crest with all the morbidity of sawing these nerves and ribs, and you reduce it to vascular access points in the groin and the leg. And it's pioneered an entire branch of vascular surgery by using patient-specific simulators for developing these techniques, and we continue to do that to run educational courses as well as do a patient-specific simulation. It allows us to show complex vascular anatomy in the kidneys, like these aneurysms with patients who have fibromuscular dysplasia. These things are very thin-walled, and when you open the patient up in the OR, you can actually see the blood swirling through the wall, so they're ready to rupture. So you'd like to know all the branch points you have before going in. In orthopedic oncology, this is Frank Sim, who pioneered a lot of orthopedic oncology at Mayo and has since retired. And this is Peter Rose, who is a protege, and now there's Matthew Hudek, who's here as well. And they've pioneered ways of taking large parts of patients out and putting them back together. It's a complex ordeal. There's multiple cuts that have to be precise. There's multiple oncologic concerns in doing this, but they've pioneered many ways to do it. And 3D printing has aided in doing that and changed some of what we do. So our index case was a 38-year-old with a large tumor in her pelvis, a chondrosarcoma. You can imagine you're a young woman facing a very large tumor. The typical surgery for this is, say, we're going to remove the right leg and do an external hemipelvectomy. Might have to take the uterus, the ovaries, the entire right leg. The surgeon asked us, P. Rose asked us for this model, in fact, before we had a color Stratasys printer, so we put the model in black, and he just thought about what are the ways I could take this tumor out of this patient with this anatomy, that I now have a way to understand it in 3 dimensions, hold it in my hand, walk around with it, sit with it at my table, and let my brain think about it. So the goal was to take the tumor out. And whenever you're taking a tumor out, you need at least a 2-centimeter margin if you're going to have any long-term support. And you can see that the hip socket had to come with this tumor for that to happen. But the printed allowed Dr. Rose to say, I think if I could remove it all, I could girdle stone, what's called girdle stone the hip up here in the iliac bone, and then lengthen the femur as time goes on so she doesn't have a limb length discrepancy. The difference between having a right leg and not having a right leg at the hip are incredibly different lifestyles. Even if you're walking with a limp, the ability to stand, the ability to not have to put on a prosthesis, the ability to walk in the grocery store, all those things were made possible by Dr. Rose, but 3D printing was a tool he used, and a tool that all of our surgeons use now that are taking sacral tumors out. Basically, no tumor goes to the OR without a model. For guided cases, this is a young patient who has a very long tumor in his leg bone above the knee. One of the ways to do that is to try and spare the knee joint and put something in the place you're going to resect. In order to do that, 1, you need a radiologist who's going to segment the borders of the tumor, and 2, you need to provide guides so that everything is accurately cut. Now, since we have in-house capability to do sterilizable osteotomy guides that are proven to be biocompatible and sterilizable, and we have a quality management system to assure accuracy, we're able to do that for this child. So here's the 3D printed guide created by engineers that are part of the surgical team in the OR, working in the Department of Radiology, and as the flesh is removed, you can see here is the guide on the leg, the saw through the guide being very precisely cut with a 2-centimeter margin. Then we have to take a bone from the leg. You have to take a cadaver bone. So this bone we don't have access to for a day before the procedure. It's coming from the biobank. We have to CT scan it and create guides for it in a day. That can only happen at the point of care. There's no time to share with a medical device company. The medical device company ships something to you, manufacture something. And then we create a cadaver bone, which has the patient's bone on the inside, with a vascular pedicle that'll keep this bone alive. It all has to fit precisely and exactly in that spot. And you can see the patient, the large portion of his femur is resected with a 2-centimeter margin, and everything fit together perfectly, saving time, but also having increased bony union when there's contact points. For orthopedics, we have a large team of people that do anything from major joint to very small bone, and 3D printing helps in many different ways as shown here. One of those ways is in the elbow. The elbow is a very complex joint. It not only moves up and down, but it rotates. So it has multiple ranges of motion, and when a patient can't move it, that means they can't bring a fork to their mouth. They can't move on and off a steering wheel. They can't reach or grab or turn or hold objects very well. And when we get x-rays, they're static. They don't provide patient-specific information. But when they ask us for 3D printed models, we create them in a way that they can move like the elbow, and the surgeon can see, okay, when this person flexes, they dislocate their radial head from their humerus. That's information that you can't get from these other modalities. And they use that to reconstruct that patient's elbow. Now here you have a 13-year-old who has a fracture in where the arm bone, his upper arm bone, connects to his elbow, and we want to place a graft from a cadaver in this place. Well, you're only going to get one shot at doing that, to resect his bone, take a cadaver bone, put it in there. There's no medical device on the market to do that. The elbow is sort of like the orphan of orthopedics, as I've been told. But with 3D printed objects, we can do that as many times as we want to trial, get the right device with the right saw, with the right piece, in order to take a piece of cadaver and plug that spot. So when we get to this part, where we have a cadaver bone in the biobank that was scanned with a day turnaround time, we can create that plug, resect that patient's elbow defect, and then place a plug into that area precisely and perfect. So one of the things that you can see here is a scaphoid fracture. So there's a normal side and a fracture. That fracture has a very high rate of delayed union. So what we've done is we've created mirror image normals, and then we've taken a vascular flap from the knee. So here's a non-weight bearing piece of cartilage from the knee that has to fit in this pace precisely, and we get one shot at it. You don't get multiple attempts at this, so it has to fit perfect. And the surgeon developed a whole practice just doing that from the confidence that 3D printing gave them. Now in this patient, you can see this severe bow-leggedness secondary to Blount's disease. And the 3D printed bone was used to be able to create an osteotomy in this bone, to be able to put multiple pins in that patient's bone, which is going to lead to small turns of each one of those little orange pieces of metal that are in the patient's bone, in order to take a bone like this and bring her back to a place where she walks upright. And this little piece of plastic helped create a very precise cut that was done in the operative room with extreme confidence to take a woman like this and bring her back to a place where she's standing upright, she gains height, and more importantly, in her community, she's not viewed as abnormal. And 3D printing was just a small role in doing that, in helping a surgeon do that. For procedures that couldn't otherwise be done, this is a case from last week that I added. This patient had a shoulder replacement in 2017, has lost so much bone on the glenoid part of her shoulder that the socket is worn down, and now she's in so much pain she's in a sling and can't use that arm. The surgeon asked us to model it and asked, can we put the screws in the thickest part of the bone? And in doing so, we made this 4-part guide, because we have an ecosystem, 4 custom osteotomy guides in multiple other bones. There's one guide that's just going to place pins to put the screw in the right place. There's one guide that's going to reshape a bone from the iliac, and then there's another guide that's going to put the humeral head in. So they have to first remove the prosthesis that's in there. They're looking down at the shoulder, and they can't see this forest through the trees. And they're going to have to put screws in very oblique planes, which this guide, this little piece of plastic here, is helping them do with confidence. Then they're going to take a piece of bone from her pelvis, bring it up, and then they're going to have to shape it so it exactly fits into place with a 3D printed guide, put the pins in the right place, like wood. You can't have too many holes in this or it will crack. And these guides, 3D printed, place these pins in very precise locations so that when that piece goes onto that scapula, it fits perfectly. Not sometimes, every time. And then you can put on that piece of bone the humeral base plate, the humeral prosthesis, and then the implant can go in. And this 4-part guide, sterilizable, 3D printed, patient-specific, that led to this implant happened in 2 days of a surgeon walking up here saying, I have a patient here from around another place in the country who I'm going to operate on, and we could do that all in-house. And that's dramatically important because that can't be done in the med device industry with a surgeon, with a custom appliance, with a sterilizable device. Now, we didn't make the prosthesis. We allow the prosthesis to go in a custom way. For prosthetic embracing, we have HP color nylon printers, which is allowing us to be able to print braces and prosthetics in ways that we couldn't otherwise do, with lattice structures, with custom lattice structures interiorly that provide cushion in multiple different areas. And there are reasons to make 3D printed braces for patient-specific hand size in a way that thermoplastics don't solve, and also for patients who need to go in the water, who need sterilizable devices to go in the OR. Like we have surgeons that need a brace that needs to be sterilized that they can wear while they operate. There's large corset braces that companies are coming to market with, but this kind of stuff is also happening at the point of care. We do simulation of rare events with 3D printing. So here's a patient with a face, a skull, a nose with flexible material. Here's a happy ENT surgeon who we work with quite frequently, and he wants to say, I want to train my residents and fellows what it's like to be in the nose doing a procedure and have an artery rupture. Very rare event, but it happens. And the way to help solve that is by 3D printing. So this simulation was allowed to move forward using 3D printed custom guides and simulators. In the same way, when we're teaching people thoracic surgery, whether at Mayo or at the American College of Surgeons, we can make 3D printed chest cages, pleura, aortas, tie pig hearts inside of them, and teach people the techniques that I just showed you in thoracic surgery to enable minimally invasive approaches using thoracoscopic techniques, but learning on 3D printed simulators instead of learning on patients. In cardiac, we do quite a bit of work across multiple disciplines in cardiac, and I'll show you just a couple of objects. Now, when our congenital surgeons are operating, you can see on your left, they're operating on the size of a wall frequently. And while we show images, very large images on the screen, in essence, you have a surgeon like these surgeons operating on something small, and they're having to try and teach someone what they're doing. So sometimes they just ask us to print out the anatomic model, which is printed life size. And you can say, well, how big is that? Well, from a picture or radiology study, you have no idea until you print it out and realize someone's going to have to move a vessel, move a piece of the heart, put a stitch in something that's that small, that you can hold in your hand. And this allows them to teach other people who are doing simulation. Sometimes we have devices that are on the market, like the Watchman device. Now, it fits most people quite well, but there's some patients who have a barren anatomy, and they want to know, does it fit this patient? And they ask us for 3D printed models. Similarly, for custom valve sizing, there might be a barren anatomy that we want to know, does that fit in that patient? And this case was from 3 weeks ago, so I added it in. It's a young boy who's on his third congenital heart surgery. He's 10 years old. After the last surgery, his heart stopped working. He went on ECMO, and they're going to have to put a left ventricular assist device in. So will this device, which doesn't come in sizes, fit in a child with a small chest and a big heart? You'd like to know that before you get in there. So they asked us to make a model of this child's heart, vasculature. We took an LVAD and we retro-engineered it from another patient's scan because they're only one size. We took that and we put it in this patient virtually, and then we put his rib cage back on and could show that, no, it wouldn't protrude through the skin, but if the heart remains the size it is on bypass, that this is going to go at least up to the rib. The ribs have some flexibility, but this allowed the surgeon to have confidence the next day. We did this in a day to say, I want to put this device in this child. Will this fit, and how much room do I have? Because he's now number one on the heart transplant list, and we need this left ventricular assist device in him, and I'd rather not find out if it fits when I'm in there. Because if it doesn't fit, this is what it looks like. You have to spread the ribs open and give this thing room to live inside the chest. For workflow, we've had to create an entire IT infrastructure which goes from an order of a clinician, which triggers, which comes either in a wired or cloud format, which triggers a protocol on the right scanner, which then leads to a 3D printing manufacturing hub. Like I said, we have 8,000 square feet of manufacturing space now here in the hospital, which then gets dictated into the patient's record. The images get stored, the files get stored, and it has to be delivered to the OR and is used as part of the timeout procedure in a way that we have a quality assurance system, in a way that the surgeon knows this is accurate. So we've had to create every step of this along with the quality checks it does in order to do at every step the education for the people who are going to train to do it, the workforce development, as well as acting like a medical device company where we have checks and balances and quality assurance steps that can be audited every step of the way. And much of this we've had to learn from the medical device industry. And I would say that the FDA has been an incredible partner through this entire process. As a community, we've co-sponsored several meetings with the FDA, Matt DePrima. Before Matt DePrima was James Colburn, who led that section in CDRH, and it's been an incredible experience building a regulatory infrastructure around point-of-care manufacturing and additive manufacturing that can allow this to happen within a hospital. So you can see there's 3 steps for us. We get an image, we transfer that image, we make something at the point of care. So we are the manufacturer. Traditionally, what would happen is we'd send that image to a company over a HIPAA-compliant cloud-based upload system, say like Biomed Zimmer, Stryker, Dupuis, Synthes. We would have to, our surgeons have to take time out of the clinic, 30 minutes, an hour, video conference with an engineer they may or may not know. File approval has to happen. They may have to re-video conference with them. It's manufactured in a traditional facility, and then that's shipped to us. That can in no way happen in 1 or 2 days. And while our average turnaround time is a week, we can do these cases that pop up on the fly. Our expansion has really been because of clinical needs and relationships, and much like COVID, a pandemic has spread around through small interactions or like social media connections. We have expanded in every surgical discipline because of we're a radiologist serving other doctors. We're allowing the doctors to have biomedical engineers on their team in the OR solving real-life problems in real time in a way that a medical device company that might have other biases or return on investment concerns can't do. Because our focus of every one of these people, surgeons, doctors at Mayo Clinic, is the needs of the patient come first. It is our only desire. That's our return on investment. We've had to overcome a lot of challenges. It's not very clear the line between medical practice and what a medical device is. It's gray, and I think the FDA and the American Society of Manufacturing Engineering, the Society of Manufacturing Engineering, the RSNA 3D SIG, the American College of Radiology have all come together to try and say, let's risk adjust this, find out what is under the scope of medical practice, and then like a custom titanium implant for even a plate is a medical device. And if we do that at the point of care, we're going to have to do it in a GMP that's an FDA-approved facility that's 13485 certified. I mean, that line is very clear. So we've had to make investments in space, personnel, facilities, IT infrastructure, things like secondary dust explosion risk mitigation, for example, if we're going to have a lot of powder, things that you just can't imagine. And we've had to invest in new types of personnel which live inside of the hospital, which all come with their own culture, which all now have to work together and liaison to bring the best possible care to a patient. And you ask how many people does it help? Well, it helps everybody from the patient to the surgeon, to the residents, the medical students, the interns, the anesthesiologists, the pathologist who's going to have to look at that specimen, and the radiologist who's going to have to do all this complex segmentation. And you have to remember, like, this is why we're here. So a patient comes, their baby has an ultrasound, their baby has its heart outside its chest, as well as a couple other anomalies. There's a 95% chance that baby dies at delivery, every time. But because we've had surgeons who have separated twins with their heart outside the body, because we have the ability to make advanced three-dimensional imaging, because we have the ability to do fetal MRI and create not the most beautiful model with the most millimeter accuracy anatomy, but to create something from an MRI where a baby is moving to allow a really talented pool of surgeons to say, this is the plan. We're going to deliver the baby. Somebody has to put their finger into the heart. Somebody has to put a stitch in the heart. Somebody has to keep the heart from turning. A surgeon's going to take more liver out of the abdomen. So there's room for the heart. And multiple specialties are in this room trying to allow this patient to live and this family go home with a living child. And 3D printing is one part of that, and the 3D printing that occurs at the point of care because it's part of the clinical team. So with that, I think I'll end. And I think I've tried to show that, like, if your system or your institution consider putting 3D printing at the point of care, it's not just what one person can do, it's imagine what all we can do together working in a hospital system to change these patients' lives. And I really appreciate you having me come here and talk to the CERSI. I also appreciate the vast amounts of work the FDA has put in specifically for additive manufacturing and the additive manufacturing community. And with that, I'll end and take some questions.
Thank you, Dr. Morris. This is really expansive and complete presentation in this topic. For anyone who has questions, please send them through the chat, and I will pass them on to Dr. Morris. So the first question, which I think to a great extent you answer, but I will bring that up again, is given that the devices appear to be unique to each patient, is design control unique to each device? Also, do you require a 510K for the Class 2 devices?
Yeah, that's a really good question. So if we just talk about anatomic models, there's the concept of what's diagnostic. So we like to produce a diagnostic anatomic model. That means that a surgeon or a clinician is going to make a decision about care from that model. It's not just like when three-dimensional imaging came out, people would say not for diagnostic imaging because it wasn't necessarily the groundswell truth. And it wasn't used for diagnosis. It was used just as a picture for representation. If a surgeon's using it to just educate a patient, it doesn't matter as much as saying we need 2-centimeter margin on that tumor. So we like to say that the models that we create based on the imaging we have are the truth of what that surgeon's going to find from an oncologic perspective, from a cardiac perspective, from a critical anatomic relationship, that's what they're going to find. And in order to do that, we have to use FDA-approved software. We have to have a quality management system that says, after we print it, how do you know the printer worked? How do you know there wasn't a scaling issue? How do you know that the printers, which don't have Six Sigma levels of reliability, did what it was supposed to do and give you the truth that you put into it? So we've had to develop that entire quality control system that's unique to point-of-care manufacturing and Mayo Clinic. That includes metrology. That includes surface scanning. That includes caliper measurements, fiducials, couponing, quality control for every printer across the entire print volume. It's laborious. We don't get 510K clearance for custom osteotomy guides because the quality management system we've built into virtual surgical planning, we believe, and we're working through some of these issues right now with the FDA on what the risk of that is, but we're not selling that on the open market. We're not marketing that on the open market as a medical device. We're performing virtual surgical planning with surgeons, radiologists, engineers as the practice of medicine under the hospital privileges. And for now, that's not a 510K cleared device. When we move into titanium implants, that's clearly a medical device, weight bearing or not, custom titanium, even plates for the mandible. That's a medical device. It's going to be in a GMP 13485 approved facility, and we're going to get FDA approval for a certain range of devices. And some of that's not worked out. Like, do you have to get 510K clearance for a radial plate that's patient-specific, that's printed, if you already have clearance for, say, the same exact plate that exists for the humerus, for the femur, for the tibia, for the mandible, or can we get clearance for a group of products that fall within a design specification? I will say that we've done a lot of work on sterilizable material. We use independent labs, Nelson's Laboratory, to confirm best case, worst case scenarios for multiple geometries that it's biocompatible and sterilizable. We've worked with our supply manufacturers of the raw material to get batch contracting so we know that we can track this device to this batch of material to this printer on this day with this quality control standard.
Great, thank you. So So the next question is, during performing a procedure in real time, if the 3D printed surgical object needs to be reshaped or readjusted or redesigned, how does 3D printing at point of care manufacturing address that need in real time? Is that a situation that has arisen in the past?
So for custom osteotomy guides, we've not had a case either in orthopedics or craniomaxillofacial or dental where the guide has had to been adjusted intraoperatively. Certainly plates, if you take your standard plate that has a locking screw or something, those are adjusted in the operative room all the time. It's part of their design approval. You know, they're FDA approved for bending based on the metal that's input. Now, when we make patient-specific guides or patient-specific plates, for example, with KLS Martin, those are very rarely changed. I can't remember a case because everything is done with such precision with virtual surgical planning that when it all comes together, it fits perfect every time. I mean, there would have to be a manufacturing defect for it not to fit, which we try and avoid, obviously. So I can't think of time. There are objects, though, like 3D printed cranioplasty plates, where you do make changes depending on how much of a tumor that can be resected, but those aren't 3D printed as of yet. Most 3D printed custom plates, weight-bearing joints, custom implants, all are made to fit perfectly and are made to not really adjust. So I would say we haven't done that.
Right, thank you. The next question was, do you ship surgical guides to Mayo facilities outside of Minnesota?
Yeah, that's another really good question. So we had one of our ENT surgeons, which uses our virtual surgical planning and guide production facility in Rochester, become the chairman of ENT in Jacksonville. Well, he certainly doesn't want to go back to not using guides. So while we set up the infrastructure needed for point-of-care manufacturing at the Jacksonville Mayo, currently there'll be a patient scanned in Jacksonville, images transferred securely because we're one enterprise to Rochester. We do the virtual surgical planning with him over a secure Skype network. And then we manufacture here and deliver there. So again, it's shipping across state lines, but we're not selling it as interstate commerce, nor are we marketing that we're performing that. We're doing it as the practice and scope of medicine within our 5-state enterprise. And I think that will continue because we have such a large central manufacturing hub here. There are going to be a large manufacturing hub in Arizona, a smaller one in Jacksonville, and then there's going to be smaller decentralized facilities in our health system across the 5-state enterprise. But that's what distributed manufacturing allows, though. It allows us to design a CAD object in Rochester, for example, and print it in Arizona. Instead of Arizona hiring, say they hire one engineer, but we have 5, then we can help with the overflow, right? Because we built the ecosystem to then deliver a CAD file, and we have the QMS system for printing that they simply deploy locally, and we have batch contracts. So I think that is certainly happening. The other thing that's been happening is we've been billing since February. So the ACR with the RSNA 3D SIG and members of our national organization have really pushed to create codes for billing, because if it's going to be the standard of care, that means you have to be able to bill for it. So we've been billing since February using Category 3 codes. There's a national registry for anatomic models and guides that's being created to develop the relative value units needed, the RVUs needed to go for Category 1 codes so that we can bill as a country for this. Because if it is the standard of care, then it's just like anything else in medicine. You know, we have standard protocols, standard operating procedures, and we have we have standard billing codes for it. So that's happening not only for what we do, but that's also going to happen for biologics. You know, stem cell manufacturing on a scaffold will most likely happen locally, regionally, and at the point of care. Skin printing is going to happen at the point of care. So those things are also going to happen, distributed manufacturing.
Great. So the next question is, what are the most exciting advances in store for the future?
I don't know. I'm pretty excited about what we're doing so far. So some people say, oh, well, anatomic models have been done for a long time in 3D printing. And you say, yeah, but why isn't it the standard of care? There are bottlenecks: printer speed, printer reliability, segmentation time, no machine learned segmentation algorithm. So even doing what we're doing at scale and operationalizing across a 5-state enterprise has been an incredible amount of work by innumerable people, from our engineers, Amy Alexander, Alejandro Dickens, to our administrators, Linda Nesberg. We have an entire team that just works on coding and billing. We have another entire team that works on GMP production facilities. We pull from the best of all these people to create what we've done, but replicating this across the country in multiple large-scale institutions is not simple, nor is it in aerospace or automotive or the defense industry. So creating, I think, exciting things are creating these turnkey solutions that can allow this to be distributed across the country in a more push-button way that relies less on the in-detail expertise we've had to develop. And then, of course, bioprinting is exciting, right? There's going to be a point where we take a part of the fibula out, we put a part of the fibula back in, that we can grow mandibles with vascular flaps, that we can grow veins so we're not harvesting veins from your leg, that we can grow skin so we're not doing skin grafting, that we're not taking large parts of you, we're not using cadaver pieces. So all that is really exciting, I think.
So next question is, planning the materials required to execute would seem complex. Would you characterize your supply chain inputs as simple or vast?
I think it's somewhere in between. So our supply chain, for example, for Formlabs, surgical resin for their printers, I think it's simple. We have batch contracting. They make it a 13485 facility. I think it's very simple. It's complex when you come to, most printer technologies will not give you batch contracting if you don't order a certain amount. So when you're working with nylons, for example, custom nylons that are maybe multiple colors, and you want contracts for the nylon, well, you're using a mix of new powder, old powder, a mix of those powders together, reclaimed powder. It's a little bit more difficult. For titanium, it gets even more difficult because there are some people who take it all the way to saying we're going to do our own electron microscopy on the powder that we're buying in large-scale batches in order to assure that our raw material that we're putting in our printer, before all the things that can go wrong in the printing phase, that our raw materials are what they say they are, particularly for weight-bearing custom implants, where if they have a failure rate, there was a large hip medical legal case at one point where the defects were traced back to the change in the raw material titanium blocks they were getting. So I think it can range anywhere from simple to complex, depending on what you're doing with that. Like, for a simple filament on an Ultimaker to make a jig or a fixture, I think that's really simple.
Great. Thank you so much for presenting, Dr. Morris. I think we are at time. Really appreciate this fantastic lecture. Thank you so much.
Yeah, thanks for having me. It was a real pleasure to be here.